Anyways, to start, welcome to our webinar with our special guest today, Isobel Mackenzie, our BC Seniors Advocate. We respectfully acknowledge that this webinar is being broadcast from traditional, ancestral, and unceded territory of the Tsleil-Waututh, Squamish, and Musqueam peoples. My name is Erin Smith, and I work for Parkgate Society out of Parkgate Community Centre in North Vancouver. I'm the manager of programs for seniors in our community. This webinar is being hosted by Silver Harbor Activity Centre and West Vancouver Senior Centre. And I want to welcome all of our North Shore seniors to this event today. Before we begin, I just want to also thank Dale Chain, our Parkgate Society Youth Services Manager, who is at the helm of this ship today, assisting me through all of this technology we call Zoom. And what we are going to do today is pretty soon we are going to have Isobel Mackenzie come and speak to us for about 30 or 45 minutes. Then we are going to open it up to questions directly to Isobel. I see a lot of them already starting, so I'd like to leave time for that. And also you can put questions into the chat that you see or into the question and answer section, which you will see on your screen. Just a little introduction here about the Office of the Seniors Advocate. The Office of the Seniors Advocate monitors and analyzes seniors' services and issues in British Columbia and makes recommendations to government and service providers to address systemic issues. The office also provides information and referrals for individuals who are navigating senior services and tracks their concerns, which helps inform future work. The office monitors services in 5 key areas: healthcare, housing, income supports, personal supports, and transportation. The office collaborates with service providers, government and health authorities to improve effectiveness, efficiency, and outcomes. A council of advisors made up of BC seniors provides the seniors advocate with advice and feedback from the perspective of seniors with diverse backgrounds, ages, geographical areas, and cultures. Each year, the seniors advocate must report to the Minister of Health on the office's activities and reports wherever possible on issues and matters arising from the office's work. The legislation outlining the mandate and duties of the seniors advocate was introduced in February 2013 and passed on March 14th, 2013. I'd like to welcome Isobel Mackenzie, who has over 20 years experience working with seniors in home care, licensed care, community services, and volunteer services. Isobel is BC's largest not-for-profit agency, serving over 6,000 seniors annually. In this work, Isobel led the implementation of a new model of dementia care that has become a national best practice and led the first safety accreditation for home care workers, among many other accomplishments. Isobel has been widely recognized for her work and has been named BC CEO of the Year for the not-for-profit sector and nominated as Provincial Health Care Hero. Prior to her appointment as seniors advocate, Isobel served on a number of national and provincial boards and commissions, including the BC Medical Services Commission, the Canadian Home Care Association, BC Care Providers, BC Care Aid and Community Health Worker Registry, and the Capital Regional District Housing Corporation. Isobel also served on the University of Victoria's Board of Governors. Isobel received both her undergraduate and graduate degrees from the University of Victoria and has a certificate in healthcare leadership from the University of Toronto. And so I would like to welcome you, Isobel. I can see you now. How are you? Thank you for joining us today. And I'm going to let you start the program.
Okay, thank you very much. I'm just going to set up a screen share here. So just, okay, well, thank you very much, and welcome to, I guess, the International Day of the Older Person, as declared by the United Nations, and National Seniors Day, as declared by our federal government. So October 1st is always a busy day for organizations that work with and for seniors, and certainly a time when we pause and take an opportunity to reflect on older adults in our society and in our lives. And this has certainly been quite a year to reflect back on, when it, for all of us, but in particular for older adults. So I know that I've spoken to a number of you in presentations at Silver Harbor over the years, and I'm not going to go over a lot of what I've already covered. I'll just give a little refresher and update, though, on some key indicators. So in terms of how many seniors there are in British Columbia, there are almost 1 million. There's 920,000 seniors in BC, defined as somebody 65 years of age or older. That's 19% of the population. And so I think what is important is to recognize that while 1 million people is a lot of people, it's still only a quarter of the population. And so when we talk about people or communities that feel marginalized, we look at where people are in the minority, not in the majority. And so very much we see that seniors today and for the foreseeable future will continue to be actually a minority of British Columbians. And that's why it's very important to make sure that we take extra efforts to ensure that their needs are being met, that we aren't falling into stereotyping traps, and that there's a sense of equity and fairness across the age spectrum. When we look at where seniors in British Columbia are living, 93% of people age 65 and over are living completely independently in their own homes. And indeed, that is where most of us will live for the entirety of our life. Even at the age of 85, which is the average age of a person in a care home in British Columbia, and it is also the age at which we start to see significant use of the healthcare system. Even at that age, 72%, 7 out of 10 British Columbians still live independently. About 80% of them are homeowners, 20% are renters. The one thing that is a little bit different is that we do see a move of homeownership from single-family home to multi-dwelling units, so condominiums and townhouses. And that is a phenomenon that we're seeing throughout our housing stock. But you do see more pronounced. We do see that movement of people selling their single-family home and moving into a condo. It's still not the dominant housing, but there is a more pronounced pattern. About 10% of people 85 and older live in what we call assisted living or retirement homes in BC. We have a funny thing here in this province around the use of the term assisted living. It means a very, very specific thing. So there's about 8,000 assisted living registered units in BC, but there's about 28,000 what we call seniors independent living, which most of you would probably think of as assisted living. So I sort of lump them together because really for the people living there, it's pretty much the same experience. And that's about where 10% of people are living at the age of 85 and over. And 15% are living in long-term care. And we know that within that 15%, there's about 2 out of 10 that could live successfully in the community, either in an assisted living setting or at home with more supports. And so that is an area that we need to pay more attention to and look at. The median income. So certainly as I talk to a lot of people on the West Shore, average incomes are higher on the West Shore, but I think it's important to remember that averages don't really tell us the story. The median income, which means 50% of the people have an income above that and 50% have below that, is 28,000, or call it 29,000 a year. So 50% of seniors in this province are living on an individual income of less than $29,000 a year. And we know that about a third of them are on the guaranteed income supplement. So they really are having significant economic challenges. It's true it doesn't count assets, But really, if you have sizable assets outside of your home, it's producing an income. And so you would see that reflected. So really, we are talking about people that are going to find that the economics of aging are challenging. Now, one of the things, the dynamics that is constantly changing and growing, and I'm always amazed every year when I see a refresh of these data, how much it's grown. So when we look at the age of 65 plus, 15% of people are still employed. And from 65 to 69, it's 30%. Now, when I started doing these presentations 5-6 years ago, that number was 25%. So just in the last 5 years, that number has grown. And I think it will continue to grow as we see people approaching the age of 65, first of all, healthier and wanting to stay engaged in the workforce. And secondly, having spent less time in the workforce than the 85 and 90-year-olds of today who approach the age of 65 with 40 or 45 years of working life behind them. We find that the soon-to-be retiree of today has taken not insignificant amounts of time out of the labor force for post-secondary education, for training, for travel, that previous generations didn't. So that's also reflected, I think, in the longer years spent working. Thought I might show you some health and wellness data as well, because I think what it highlights is a reminder to us that frailty and ill health are not necessarily a definitive outcome of the aging process. However, we do see that as we grow older, we do use the healthcare system more frequently. So the top part, population growth, just when you look at relative ages, you do see that the population change for people over the age of 65 is higher than in previous, than in people under the age of 65, and that is continuing to grow. But the absolute number of people, obviously, there's still a greater number under 65. The dementia diagnosis data I find is always interesting, because if we look at the population under 65, it's less than 1%, it doesn't even really register, of the population diagnosed with dementia. Now, early onset dementia is particularly challenging for the very reason that so few people have it. Is it probable? No. Is it possible? Yes. And younger people with dementia have very different needs than older people with dementia. And of course, the challenge is there aren't the services there to support them because there are so few. And that, in fact, exacerbates the challenges that they have. When we look at the total population over the age of 65, 6% have a diagnosis of dementia, or put another way, 94% of people over the age of 65 don't have dementia. Between the ages of 65 and 84, we see actually only 3% of the population. And that's because when we look at 85 plus, 20% of the population, 85 and over, do have a diagnosis of dementia. So it really does, the probability does significantly increase as we age. But the important thing that I would ask you to focus on is that although 20%, 2 out of 10 people over the age of 85 have a diagnosis of dementia, 8 out of 10 people over the age of 85 do not have a diagnosis of dementia. And that's what I really want people to focus on, because the stereotyping of the much older adult, the 85, 90, 95-year-old, is giving an impression of the inevitability of dementia, when that is indeed not the case. The probability absolutely increases as we get older, but the inevitability of it is absolutely not there either. And so we really need to think about that in our approaches to a lot of things and in the assumptions that we make about a lot of older adults. When we look at healthcare, so again, you can see when we look at under 65, 65 plus, and then 85 plus, that people under the age of 65 are relatively healthy. 60% of us we're non-users of healthcare, and we're a healthy population. We're not going to the hospital, we're not getting surgeries, and we're not going to our doctor very frequently. As you get to the age of 65, that flips around. So people over the age of 65, only 13% aren't using the system. So as you would expect, that's what about 87% of people 65 plus are using the healthcare system. What's interesting is when you look at 65 to 84, that number really doesn't change dramatically, but it changes at 85 plus. So that's really where you're starting to see 95% of people 85 and over are becoming users of the healthcare system in a fairly prolific way. But they're not necessarily frail or have highly complex chronic conditions. So if you look at the far right of the slide, 85 plus population, you can see that 35% do have high complexity chronic conditions at the age of 85 plus, but 14% have low complexity chronic conditions added to the 5% who are healthy, so that's almost 20%. And then you add it to the 28% who have medium complexity chronic conditions. And then pulling out of that population is the 15% who are frail and in residential care or at end of life. So where are people living? I've gone over where they're living in terms of independently and retirement, assisted living and long-term care. And what's important when we look at these data is to recognize support for people as they age is not all about long-term care. We're hearing a lot about long-term care right now. There are definitely issues, things we need to address, but it is a much smaller portion of the older population than the people who are living independently. And what do they need? They need better coordinated community services. They need better home supports. In British Columbia, they need to be more affordable. They need more supports for the family caregivers. Although one of the things that COVID-19 has reminded us of, particularly with regard to the residential care visiting restrictions, is there's family caregivers for people in long-term care as well. And one of the things that I feel very strongly about, which is we need more choice and affordability in assisted living. And that links back to that population in long-term care who could be well served in an assisted living setting, but they can't afford it. And we have a much higher waiting list in terms of the ratio of people waiting to number of beds for our subsidized assisted living than we do for actually our subsidized long-term care. So I'll just give you about the issues in long-term care. We've been hearing a lot about those. I think the important thing to recognize is that these issues existed prior to COVID. They're going to exist after COVID, but as a result of COVID, some of them are likely going to be fixed or at least made better. And I think that's something that gives us hope and is one of the things, positive things that will come out of this pandemic. And I think there's a report my office authored. It's on our website, A Billion Reasons to Care. And those of you who are interested in this can go and read that report at your leisure pleasure. So I'm going to give just a little bit of a snapshot of where we are right now with our COVID numbers in British Columbia. And I'm just looking at the order of my slides, and they're a little bit out of order, so I'm going to do a bit of skipping forwards and backwards. But I think what I'm going to do, so before I get into the numbers of where we are, following on most people living independently and issues in long-term care are significant and important, but when we look at the impact of COVID-19, there's been an impact on our population outside of long-term care as well. So when the pandemic hit, fitness centers, recreation centers closed, senior centers closed, libraries closed. Most places that allowed for socialization of seniors closed. And then, of course, what was discovered by many people that wasn't news to those of us who work in the older adult population was that a number of seniors access to the internet is at the public library or the senior center because they can't afford the monthly charge for the internet. And of course, they were cut off once their ability to go to the senior center or library was cut off. Slowly, some of these have come back online. Not all of them have come back, and none of them have come back to resemble what they were pre-COVID. And they require reduced usage, not as effective in terms of access. And then, of course, some seniors are very concerned right now about going out and about, and so they're limiting themselves from going to some of the things that they used to participate in pre-COVID. When we look on the care side, certainly whether many seniors require assistance with their foot care. They'd have a foot care nurse come and visit them once a month, or they'd go out to an aesthetics place for to have some foot care. None of that was available during the most significant part of the lockdown. Much of that has eased recently, and so, but it's a bit of a warning sign that for some people they need other people in order to do their foot care, and they don't live in a care home where it's going to be done for them. And what is that going to look like? Physician care. Now, this is one where we're not sure, was this a good thing? Was this a bad thing? Or sort of there's good and bad to it, which is most physicians closed their offices to patients coming in. They converted to a virtual care model out of necessity as the mother of invention, and a number of physicians who might have been dragged kicking and screaming into some of these virtual environments found that they had to quickly adapt. It was the only way that they were going to be able to see their patients. Most physicians have retained an element of that ongoing. You can go into a physician's office. Most physicians will make available an in-office visit when necessary, but what remains to be seen is with virtual care, there could be a number of seniors who in the past, the ability to physically get to the doctor's office was an impediment. And so in fact, they're getting better or more timely care now because they can be assisted by their daughter or their care aide or their spouse to Zoom in some virtual way and discuss their issues with the doctors. And so, it'll take about a year or so before we're able to look back and see whether that actually has produced a positive outcome. Acute care and the cancellations and postponements of surgeries. The reports from the provincial government are encouraging in terms of catching up, but certainly those delays will have had an impact, particularly on people whose surgery was for a hip replacement, a knee replacement, some kind of orthopedic surgery, something that was impeding their mobility. It might have been the coronary artery bypass graft that, their capacity to, their stamina was greatly reduced. And so they reduced their activities for a more prolonged period of time. It will take some time to judge the real impact of that. And in cases like this, sometimes patterns are not pronounced enough to really produce a strong statistical outcome or evidence. But it's a subtle experience by many and a very strong experience by a few, and that will, I think, prove to make it difficult to really pin down the true impact of these reduced and delayed surgeries. Our home and community care program, home care nursing, home support, did continue throughout the pandemic. We didn't have any outbreaks in our home and community care, home support or home nursing care in the province. Many clients resisted or reduced the service because they were concerned about people coming in. We planned for but never reached the necessity of implementing essential service levels. And I don't think that we will reach that, although with cold and flu season coming, we are concerned that a number of people will develop symptoms. Those symptoms of cold and flu mimic to a large extent symptoms of COVID-19. And of course, you will have to remove yourself until you can get tested and be reassured that it is COVID-19. And so we're a little bit concerned about what that will be. But fingers crossed we'll be okay. Our adult day programs, we did close those, and we closed them for rather a long time. And my office is looking at measuring what happened to people in adult day program during a 4-month period in 2019 and comparing it to a 4 to 5-month period in 2020 to see if we saw more frequent trips to the hospital or a higher rate of referral to long-term care. They're opening up now very slowly. And part of the challenge is the concern of some of the participants about coming into the adult day programs. And certainly congregate care, long-term care, assisted living, independent living, we've certainly seen the challenges there and the challenges around the visitor restrictions. And my office has just concluded a survey on the visitor restrictions, and we'll be reporting out on that by the end of the month. Okay, so now I'm going to talk about our latest numbers. These are accurate up to the end of the day, Tuesday of this week. So we have 560 long-term care and assisted living sites in BC that represent about 40,000 people that are under the provincial health officer orders. And there are a lot of places that many of you will think of as being assisted living that really isn't. They're seniors independent living, and they're not captured by the orders. The orders are Community Care and Assisted Living Act sites and Hospital Act sites that are governed that way. So there's 560 of them. 55 of these facilities or sites experienced an outbreak, so about 10% so far have experienced an outbreak, and 90% so far have not experienced an outbreak. The 55 facilities that experienced outbreaks, it's 62 outbreaks in total. That's because some facilities have experienced more than one outbreak. What I think is important to note, 38 of the outbreaks had no deaths to date coming from that outbreak. So that is more than half had no deaths associated. 27 of them to date were contained to a single staff member. And that is also important to know, in the normal pre-COVID world, we would not declare an outbreak until there were 2 cases, one laboratory confirmed, to declare an outbreak. And we introduce infection control, usually around a norovirus and influenza. It could have been a pneumococcal outbreak. And those are not uncommon. We usually have about over 100 of them a year in our various places across the province. For COVID, one of the things we did, and I think it's one of the reasons why BC has to date performed better than other large provinces such as Ontario and Quebec, is that we lowered that threshold to 1 confirmed case, and at which point we declare an outbreak and incoming infection controls. When it's contained to a single staff member, you're going to know within probably 3 or 4 days if it's going to stay contained to the single staff member, because you would start to see other cases pop up if there'd been a spread. 7 outbreaks, were contained to a single resident. And that, of course, raises the question, how did that single resident get the virus? We're looking at those 7 cases. It is unusual. In the early part of the pandemic, it is possible that it is a resident. Some of these will be residents who were transferred in from hospital or admitted from the community, and they developed the virus while they were being isolated for 14 days in the care home. That will be part of this number. It is also possible, it's not probable, but it is possible to have a false positive. The test is not 100% accurate. It tends to err more on a false negative than a false positive, but it is possible that when you only see 1 case and no spread, that case was a false positive. Sometimes we will test again if we think that is the case, but part of the challenge is you could have COVID, Once your viral load drops, you're going to test negative again. Although the antigen test could be effective in detecting that. 6 of the outbreaks were contained to 2 to 5 people, combination of residents and staff. We would consider that a contained outbreak in my world. 11 of the outbreaks were 6 to 15 residents, so that's a little bit more than we like to see, but that can sometimes contain it to a specific unit within a care home. And then we see 11 of them had more than 15 residents or staff combination. And those are what we would call a bit out of control. And more of those were at the beginning of the pandemic. So currently, as of September 30th, so this would be yesterday's data, we have 13 active outbreaks in long-term care and assisted living in BC. 6% of our outbreaks have been in publicly operated care homes and 84% in contracted care homes and 10% in fully private care homes. 141 residents in long-term care and assisted living have passed away from COVID-19. That's 61 of our COVID deaths. So we have a slightly lower ratio in our care homes than some of the other provinces do of our deaths in long-term care, but we also have a lower percentage of our cases relative to the population. 667 cases so far in long-term care and assisted living, 400 residents, 267 staff. Now, one of the things that's interesting is this graph at the bottom. So I'll just go through these lines. This is starting back on the 5th of March, taking us through to the 24th of September. And so this darker line here that you're following, these are the total number of outbreaks that we have. This includes, I should add, residential care assisted living where there was a hospital unit outbreak as well. So it's a little bit higher than our total outbreak. This line here, this sort of lighter aqua, I guess, line, these are the outbreaks that were a single staff member. So we saw that as we got into it, more of the outbreaks were beyond the single staff member. That was it at the beginning, and it went up and went down. This green line here is the 5-day rolling average of cases in the community. And that's what's very important to look at, particularly now when we see large numbers of cases each day, when we were used to a smaller number of cases. But when we had a smaller number of cases, this green line here versus here we are today, we had more outbreaks than we are experiencing right now, right? So the numbers have inverted. We had higher outbreaks relative to our number of cases. Now we have higher caseloads relative to our outbreaks. And we are seeing this line, which is outbreaks that are restricted to a single staff member, again, rising. And that's a good thing. You want to see that. So I think that that's part of what goes into the mix when we're looking, and you've heard this from our PHO. She's been very clear that there's a lot of moving parts you look at, not just one thing. The number of cases is but one measure. Who is getting it? Can we trace? What are our hospitalization rates? What's happening in our vulnerable populations like long-term care? And so even though we are concerned about our high number of cases, some of the other metrics are not causing us the degree of concern that they would have back here when we were in our peak of the beginning of the pandemic. Okay, so I think that is the end of my update, and I'm more than happy to answer any questions, and I'm going to hit stop share on the screen here. Okay, and
Isobel.
Turn it back.
Hi, Isobel. It's Erin here.
Hi, Erin.
Hi. Thank you very much. That is a lot of information to take in. We have a lot of questions here. They seem to be mostly around, of course, the question of long-term care. We also have some on transportation. Now, how I think I'm going to do this is I'll take the questions from Silver Harbor that were given to me before we started today, and some of those are on transportation. And then maybe we'll get through the other ones that have come up as you were talking. Does that sound good?
Yeah.
Okay, so there's a question from Silver Harbor from a senior who is probably sitting at Silver Harbor today watching this streaming regarding the Seniors Advocates Report on Transportation from 2018. One, it says there's been no reply from transportation agencies nor cities, regional districts. There was only the one, so there's no other part to that.
Okay. That's correct. So we did issue a transportation report with recommendations back in 2018, and that followed a very wide, about a year and a half consultation with a number of folks. And we made some recommendations around certainly how we could improve HandyDART, how we could improve our public transit system. But one of the big recommendations that we tried to focus on was addressing the needs of the population who really aren't able to get on the bus or travel alone successfully, and how were we going to get them the assistance to be able to get out and about. And that is part of what is in the mix that I think is still being discussed within our home support program, is whether we could expand that so that driving clients around could be possibly part of that. So that is under discussion. The one area we actually have seen some, I think, added resources and some recognition of the report is some of the increases to the Better at Home program, increases in funding that will probably, I think without COVID, we would have seen them earlier. I think the challenge is that volunteer drivers are difficult to get in the best of times, and more difficult during COVID. And people are a bit worried actually about traveling in vehicles with another person at the moment. But that is certainly something that we are expecting to see, which is the additional funding that's gone to Better at Home, which is rolling out over the next year or so. Again, we haven't seen the full impact of it because the promise has been made, but it's money that is expended over a 2-year period of time, right? So most agencies probably have not felt the impact of that, the full impact. Some will have received some of the funding, but there's more coming. And so hopefully that will help create some more transportation options.
Another question about transportation, Isobel, is in regards to COVID and suggesting that the transit services have been reduced on many routes, longer waits for seniors who are also unable to stand for long times, where they're seen in other big Canadian cities, pre-COVID levels of service has returned, but not in Metro Vancouver.
I don't know. It's a good question that I have not had a conversation with TransLink in the last 2 months. So I'm not aware of where they are at in their plan to return to full service levels. And I will check back with them about where we're at with returning to those full service levels. That was certainly the plan. And I'm not sure where they're at with that.
Okay, I think we'll move on. I've got a lot of questions here about our families and family members and elders in long-term care. The question here is that they continue to be denied meaningful access to people who love them. They believe it's become a human rights issue, as it's now been almost 7 months and we need help to change this. It's not okay. What can be done?
Yeah, by the end of this month, which is the soonest we, the challenge is this. We don't actually have an organized way to get feedback from families and residents of our long-term care homes in British Columbia. There is no provincial association. There is no, right? That's one of the things that's become obvious. And I'm certainly going to be making some recommendations around that. So we went out with a survey that asks some very meaningful questions of family members and residents about their visits so that we can get an understanding of the degree of the issue. And certainly the survey closed, I think, last night at midnight. I've had a preliminary look at some of the data. And certainly it is the experience of many families is not what I think most of us would agree is acceptable for the next year and a half, right? Because we're looking at the next year for sure in long-term care, maybe a year and a half before we fully return to life as normal. Because that's the last place we're going to see that, because it's the most vulnerable population. So once we're talking about that, I think a lot of people realize 30 minutes once a week is just not going to do it. And some are even less frequent than that. So I think, I know they're working on it. I think the survey was a bit of an impetus for some care homes to look at the restrictions they had in place. I think that what comes through in the survey is the variety of experiences with care home visiting, that some are finding the experience okay. Some are finding it absolutely not okay. There's the group of people, there's almost two issues. One is only the one designated visitor. So that is creating an issue for families who, for the next year and a half, nobody else can see mom but the one sister, right? I think we can all appreciate the dynamic that's going to set up. And the other issue is, irrespective of whether it's one or two or three visitors, how frequent are the visits, how long are the visits, and where are the visits? And we've certainly seen diversity. So my hope is that through this very strong voice, I think we've got about 13,000 responses. It's going to be a very clear indication of where we need to be going as we look at the year ahead. And we may even get there before I release the report at the end of the month.
Thank you. Yes, as I'm looking through, I mean, there is definitely a theme here of obviously individuals who are really challenged by the difficulties that they have with their family members in long-term care. And I think you've touched on where we're at there. Let's see if I can get onto another question here for you. Yeah, here's one from Joy Parsons. And I don't know if you have this information, but of all the long-term care homes, what percentage are public, contracted, and fully private?
I do have that information. I'll give you the sort of the thumbnail sketch is that we have publicly funded, which breaks down into about a third of them are owned and operated by health authorities, about a third of them are owned and operated by not-for-profit societies, and about a third of them are operated by for-profit companies. So those are under the publicly funded, the 28,000 and some odd beds. Then we have about 1,600 beds or so that are paid for privately, but they're within a publicly funded care home. So a care home might have 100 publicly funded beds and 10 private. So it's basically the same experience for everybody. It's just they've got 10 beds that you can pay for privately if you don't want to be on the waiting list. Then we've got about 3,000 beds, so about 10% of all of our long-term care beds that are completely private. They're in a private care home that only has private beds. So I guess the better way to describe it is this: about 87% of all licensed long-term care beds in this province are publicly subsidized, and about 13% are privately paid for. Of the 13% that are privately paid for, 10% are in completely private care homes, and about 3% are in a mixed model. When we look at our publicly funded beds, again, a third, a third, a third. A third owned and operated by health authorities, a third by not-for-profit societies, and a third by private companies.
Thank you. Jennifer Cannon asks, what are your thoughts on how we make sure the most vulnerable seniors can safely access a COVID vaccine when one is available?
That's not going to be my decision. I can assure you that the decisions on who gets the vaccine and who gets what vaccine and when, those will be decisions made by public health, and they'll be evidence-based. And we do know that the most vulnerable population to the serious illness developing from COVID-19 is frail elderly, and particularly in long-term care. But we don't know how effective the vaccine is going to be for that population, right? So we may find that if you've got a limited amount of vaccine, you're actually better off to vaccinate all the care staff because it's highly effective in younger immune systems. So they're not bringing it in than it is to vaccinate all the residents. I don't know. Those will be decisions that will be made by public health and prioritized. I do know, as all of you do who follow the news, that Canada certainly has purchased a number of vaccines. What I will give a shout out to right now is before the COVID vaccine, there's the flu vaccine, and just encouraging everyone to get the flu vaccine. And again, one of the messages I'm going to reinforce this year is if you really want to protect your mom or your grandma from getting the flu, get yourself vaccinated. That's actually even more effective than getting your grandma vaccinated. Absolutely, 85 and 90-year-olds should be vaccinated. Absolutely, the vaccine can be effective, but we also know it's less effective on older immune systems than younger immune systems.
That's great, thank you. A question again from Silver Harbor, from Veronica Trail of North Vancouver. There's a growing number of seniors living in homeless shelters. Is there a way of collecting data on these seniors and how we can support them?
So it is a growing population in terms of the number. It's a small number. Part of the challenge is that in the homeless population, 55 and 60 can often present as a senior. One of the things that I am concerned about is that one of our solutions for seniors in homeless shelters is to put them into long-term care. And in Vancouver, more so on the other side of the bridge from the North Shore, we are seeing some evidence of that. There's people in long-term care really because it's their housing solution, not their healthcare solution. That's not a good place for them to be if that's not what they need, and it's very expensive. So we are certainly looking at, what are the supports that we can give to particularly why someone might have become homeless at an older age. I think that is probably what we can prevent the most. Somebody who's been homeless all of their life, or most of their adult life, or the last number of years, and becomes a senior, that's a different issue and a different solution, possibly. But somebody who's been living on their own until they're 65 or 70 and become homeless at that age, that's where I think we need to look at what caused that and how can we prevent that.
Thank you. From Inga Shamborsky, we have been hearing about the residents and the people receiving care. What are we hearing about the caregivers looking after their loved ones at home?
That's a good question, Inga. We are worried about, I'm particularly worried about caregivers who have been accessing ADP and what the strain on them has been. We do hear, from people, not the mass of other issues we've heard about, for example, like the long-term care visits. But we are very concerned about what has been the burden on the caregivers living at home and the lag in what we call the lag indicator, right? So we did have a case at 2 cases that I can think of at this office where because of the cancellation of ADP, where their spouse went 3 days a week, so that's a significant, within 2 months, 2.5 months, they couldn't cope anymore and they had to place their loved one. So that's where I say we're going to be looking at, what did these 4 months look like in 2019? We may actually be able to do it on a 5-month view now, and compare that to the 5 months in 2020 when there was no ADP. And we're interested to see if we're going to find a higher likelihood that they were placed in long-term care, higher likelihood that they went to the hospital.
I've got one little short statement here that says need washrooms at major stops. And I think that this probably is quite specific to COVID times when it is hard to find washrooms. And I wonder if maybe the solution has been thought to actually just provide portable toilets close to major bus stops, things like that during the COVID pandemic.
Toilets are complicated, as you find out when you start to look for these solutions, like washrooms at SkyTrain stations and other kinds of access. And they're complicated because it's not just providing the toilet. The toilet has to be maintained, who's going to use the toilet, what kinds of activities are going to happen in toilets that toilets weren't intended to provide the opportunity for. These are the types of issues that local government is wrestling with when they're looking at providing restrooms for the public to use. You are right that the reduced number of restaurants and establishments that will allow people to use their toilet, that is definitely creating a problem. It is unclear what the solution is because you've got, as I say, it's not just about you put the toilet out there, but the same reasons why the establishment doesn't want to use the toilet. How are we controlling for that when people use the toilet, right? There are, I think there are some toilets, I've certainly seen them in Europe, they sort of totally spray wash after you leave them. It's unclear to me how friendly those toilets would be for older adults, particularly somebody with any kind of mobility challenge. I mean, we have to think about that as well, right? And you don't want to set up an unsafe environment where somebody is likely to fall because they're trying to use a toilet that really is not accessible to their needs.
We have another question out of Silver Harbor. Do we know yet the impact of COVID isolation on seniors out of workforce in relation to their mental health and cognitive level of functioning? We've asked that question on our long-term care survey of the family visitors, and I've had a peek at the data. I don't want to, but I haven't it hasn't been super analyzed. But I think I think there is going to certainly be a sense that there's been decline. Now, one of the questions that will be raised is what decline was simply the passage of time, period, and what decline has been accelerated due to the isolation. And one of the things we always have to tease out, because we talk about isolation and loneliness exacerbating or accelerating a dementia, but I think some of us are not clear, is it the actual dementia that has accelerated or been exacerbated, or is it depression? So, because of course there are things that we can reverse and things that we can't reverse. And so if we think about the ability to, and there's some evidence of this,
If we think a person has declined because of the isolation or not having been able, and then when they are able to connect with their loved ones again, you see a rebound, that is probably more related to a depression. And I think that that's what well, frankly, that's a whole other topic for a whole other day, is how often are we describing what is really a depression as dementia simply because the person experiencing or presenting the symptoms is 85, right? If they were 45 or 30, and you can treat depression. So that's something we need to think about.
Thanks, Isobel. We've got a couple of questions here from an attendee. They seem to both be around the topic of allowing families in long-term care individuals to come out of the facility. One has asked, can we let the elders who can get out? What can we do to get the decision makers to restore their rights? The other question is about a woman who would like to take her mom for a walk in the park next door to the long-term care facility she's living in. They don't even need to get in a vehicle. They just want to get out together. She could wear a mask. Do you think that these restrictions will be loosened in the coming months?
So I just want to back up, Erin. The person's mom is in long-term care or in assisted living?
Long-term care. Both these questions were about family members in long-term care.
And they just want to take their mom out for an outing.
Yes.
They should be allowed to do that. Again, because case in point, people go out for medical appointments, they come back in. They should not be subject to 14-day isolation as a result of doing that. There's a difference if you were to take your mom home for a month or two. I do believe they would be isolated for 14 days upon return. But I would encourage them to have a conversation with the care home about, where in the health orders does it say they can't do that?
Yeah, okay. Sorry. Lockery Munyon has asked, how can we have Bonnie Henry come and see us in person and get some straightforward and concrete answers? Saying we are the most vulnerable group who has suffered the most, then why don't they do something now? Well,
I think certainly, Bonnie, you can invite Dr. Henry, and she does talk to people and has, this kind of forum, so you may be able to get her to come and speak to you.
Deborah Stephen has asked, is there a place to look at the care ratings of different care homes?
There's a quick facts directory on our website. We don't technically quote unquote rate because of course rating systems, what are you going to use? But you can go on and find out a lot of information about a care home, and you can compare it to other care homes, and you can make your own decision about how important different things are to you. So you can find out how many beds they have, how many private rooms they have, how many care hours they're funded to deliver, what kind of physiotherapy they're delivering, so on and so forth.
Okay, thank you. We are coming to we do still have time. So if you guys have more questions, you can put them into the question and answer section or the chat. The rest of the questions that I see here, Isobel, are really, again, more about the long-term care and the frustration that people are having with being unable to see their loved ones. One of the participants here today says, in your words, what are we saving them from? And I guess the feeling is, I've heard you speak so eloquently before, and I always try to bring this into my work here when I'm working with seniors, and that's we need to give them enough dignity that they can take the amount of risk that they choose to take. And some people are more risk adverse and other people are not. And obviously we're in a pandemic and some difficult decisions have to be made. But I guess that sentiment of what are we saving them from is a good question. I don't know if you have thoughts around that.
Well, I think it was, what are we saving them for? We're saving them from COVID, but what are we saving them for? And I think that this will come through in the survey, which is the voice of the residents and their family members. And I think that it is a difficult and challenging situation for the public health officials, because there's a mathematical reality. The mathematical reality is that the more people that come into a care home, the increased possibility, not probability, but possibility, that one of those people will carry the virus and it will get in the care home. That is true. We know that it's a very frail and vulnerable population. As I said, 61% of our deaths, our COVID deaths, have been in care homes. So we know that. But we are talking about, in the period of time when 141 people passed away from COVID in our care homes, about 3,300 people passed away in our care homes from something other than COVID. And bad things happen in care homes. People fall. We make medication errors. We don't necessarily provide appropriate wound care, all of which can lead to preventable deaths, because that is COVID is categorized as a preventable death if we prevent you from getting it. Now, that's not what happens with most people. Most people who pass away in a care home die from an illness or a condition that it was not preventable. It was in fact an unexpected death. We know that. But I think we have to sort of step back and say, okay, we're talking about the next year. We're not talking about a 2-month lockdown here. We're talking about people's lives effectively for the rest of their life. And what is that going to look like? And there is this little risk, there is a risk. We know how to control for that risk to a large extent. And what are we saving them for? Because we're not saving them from dying, right? We're saving them from getting COVID. And most of them, in the period of time that we're saving them from COVID, are going to die of something other than COVID. And during that period of time, they are not going to have had the daily couple of hour visits from their daughter or their spouse that they were having before COVID. So for what purpose, right? It's a very difficult conversation to have. It's a very emotional conversation to have. And that's why I committed to, let's ask the people directly affected by this, which is the family and the residents, what they think. There's not going to be 100% unanimity, and it's a shared risk, and that is the biggest problem, right? So if 90% of the care home residents say, no, we want more frequent visits and we're okay with the risk, what about the 10% who say, no, we're not okay with that risk, and what's our duty and obligation for that group? But we make these decisions life is risk, and it's we know how to reduce the risk. We know a lot more about, and one of the things we have to remember with some of these outbreaks we're seeing now in care homes, there's a difference between we know what to do and we're doing what we know we have to do, right? So we shouldn't assume that just because we're seeing some care home outbreaks now that we still don't know what to do. We do, but we would be naive to think that we're doing it absolutely right all the time. So I think that that's some of the conversation that we have to have. But certainly, I do think that we have got to find a way of having a meaningful life for people who live in long-term care. And for many of them, that is the time they spend with their loved ones.
Mm-hmm. Yeah, thank you. I wondered if we can talk, Isobel, a little bit about the staffing of the long-term care facilities, what that used to look like, how things have changed during the time of the pandemic, and maybe what you might see that looking like in the future.
The change is not as dramatic. There's been some changes. So if we say, what was staffing like before COVID-19? Staffing, there's a lot of different things. So box number one is, how many hours of care did we fund for residents? And before COVID-19, we were seeing an increase in the funded hours of care to all of the publicly funded care homes, whether they were operated by a private company or a not-for-profit or owned and operated. We were seeing a steady increase in those hours. We had not yet developed a robust system to ensure that the funded hours of care were delivered. That's in the works, as they say, but we're certainly moving towards that as well. Then there's the question about how and who delivers those hours of care. So certainly before COVID, we saw, and I would say we still have it, the fragmentation with the contracted providers. And certainly Lynn Valley, which was the first outbreak in Canada, not just in BC, in a care home, was the poster child for how fragmented this can be. They had one company that hired the care aides and one company that hired the food service workers. I think they had another company that was the housekeeping staff, and then the nursing staff were directly employed. So it presented in full form right out the gate all the challenges. So what the PHO did was that, and she certainly knew of this and knew before, and at least how do you fix these. She moved very, very quickly around two issues. Staff moving from location to location. And we certainly, at the very beginning of the pandemic between care homes, that is absolutely what we saw. So you can't work in multiple care homes, because if you're working in one with an outbreak, you could be causing another outbreak, right? We've got to keep you contained. And then from that flowed, you've all got to be paid the same wage rate, because we can't have people saying everybody wants to work at this care home because they pay the higher wage rates. So what we've got right now is a workforce who, regardless of who employs them, and there still is this issue of multiple employers on one site, because that has to do with certainly issues around leadership and standardization of training and protocols, et cetera. But they're all paid the same wage rate, and they are restricted to working only at that site. Now, they're not restricted from other jobs in the community. They're not restricted. It's not as, it's an added layer of protection, but it's not saying that this person, simply goes from this care home and has no it's not that airtight. I mean, I don't think we can get to that point, but it has certainly been an added layer of protection. It's caused some challenges, because a lot of care homes would depend on casual staff, certainly around sick leave and things like that. And so, where's your casual pool? But we'll work that out, I think, in the months ahead. We definitely need more staff, we need more people to choose being a care aide as a career. But by standardizing the wages, by creating permanent jobs, you will attract more people. Because when you're deciding what you want to do, and your choice is, I can be a secretary and make $50,000 a year and work Monday to Friday and from 9 to 5, or I can be a care aide and make $32,000 a year and have to, go to have a schedule that's sometimes nights, sometimes weekends. I may or may not get benefits. I'm going to choose this. Now, when my choice is, I can be a care aide and make $55,000 a year and all these stuff, and I really want to do it, I'm going to choose that. Some other people are still going to choose the other job because it's being a healthcare provider, frontline healthcare provider, is not for everybody. It doesn't have to do with how smart you are. It doesn't even have to do with how empathetic you are. There's just certain realities involved in the job that some people just cannot do. And so, but I think for the people who want to do it, but the reason that they didn't do it is because I make more money over here, those people are going to go into that profession. And you're going to see that it will take a year or 2 or 3 before you feel the full impact of that, because people have to train and they have to, but I think we have definitely started started the ball rolling to address that to a large extent.
So we have a few more questions about care aids and care homes cropping up now. This is from Kim Chambers. Our facility has had 2 visitation people assigned to check people before visits for 1 month now. I've only been checked once during this time. I feel the money would be better spent on helping our loved ones when it's a position that isn't even bothering to do their jobs. Sorry.
Well, I
Let me
think
try to make sense of.
Well, I think I get Kim's point, which is people aren't doing what they're supposed to do. And believe me, I know that. I know that not just in this job, but in my previous job, when my job was to make people do what they were supposed to do. And that's a challenge. That does come through in the survey, I have to tell you, that there are people who say, yeah, no, I'm not getting checked. Those will be some questions that will be raised, I believe, I hope, because the government, to its credit, did fund and did tell operators, we will fund you extra dollars. There's been a lot of money going out to care homes. And the kinds of people that you hire that need to be hired to do the screening you don't need a care background to get somebody to fill out a questionnaire and to ask them some questions and to take their temperature. Anybody can do that. So you could hire people to do that. And it's just, I think, we've got to be a little bit more able to understand and see things. The care home exists not to be a care home. It exists as a place for people to live, quite frankly, probably in the last couple of years of their life. And it's about the people that live there. It's not about all of us running around in the care home and our needs. And we've got to refocus that and understand really why it is we come to work every day. And many people do. But I think as a system, we've maybe got a little bit of introspection that we could be doing about, are we really approaching this from what do the people we're here to serve want?
So let's see. Oh, yes. Okay. So here's another question from Kim about staff at the facilities, that she's hearing that to make up their income, they're getting, because they're staying in site specific, they are getting second jobs in retail or home care, etc. Her question is, how is that safer for our seniors than us visiting them?
It's a good point. I mean, now, in theory, what is supposed to be happening is if you worked 40 hours before in 2 sites, you're going to work 40 hours now in 1 site. I can believe that as it's played out, that may be the case for most people, but there may be some people who picked up some casual hours and they aren't able to do that now. And how do they now? One of the things to remember is most care aides are earning more per hour now than they were. So we need to remember that. The majority of care aides got a wage lift when the wages were leveled. So they may be working fewer hours, but they're getting paid more per hour that they're working. There is, I think, here's the challenge. You could say to care workers, you can't hold any other job anywhere. but you need to think about the unintended consequences of that. And one of the unintended consequences is that they won't tell you of the other jobs they have. And when you're trying to do contact tracing and keep pandemic, that's a dangerous thing. You need to know where people have been, and you need to create an environment where they're not going to be afraid to tell you where they've been, because they're going to get punished for having done something they shouldn't have done. So you got to think that through. And I think that if the public health message is still that we have fairly low community transmission, which is defined as cases we can't trace. And so it is, if we had high rates of community transmission, we may find that there would be further restrictions on the mobility of people who work in healthcare. We don't know that yet. We don't arguably need that yet. It is true that the outbreaks, that it is staff bringing the virus in. They don't know they're bringing the virus in, but we also know that they're not contracting it from the grocery store. For the most part, it's in those close family households that the virus is transmitting.
Thank you very much, Isobel. It is now 2:22. I think I will take one more question. This question was about private long-term care facilities, and what do you see as the future of private care in British Columbia?
Well, I think the private care in and of itself, well, first of all, there's two buckets. There's private care where you as Erin pay privately, it's a private care home, it's licensed and has oversight, but the level of care you get is dictated by what you're paying, right? So I think that is always going to exist and should be allowed to exist. There's many seniors, it can be very costly. I mean, there's lots of places where people are spending $15,000 a month. And I predict they're getting very good care because they're spending $15,000 a month. So that's a small number in BC, so I think we just put that to the side. The other question is the private care homes that are delivering public care with public dollars. And so the difference there is that the government is giving them money and expecting them to deliver some services, but what's the oversight to make sure they're delivering those services? So I think before we say, you can't have private care homes deliver publicly funded care. First of all, there's the practicalities of it. 2/3 of our care homes are contracted either as a not-for-profit or a private company. So that's, we've got to work with that. And I just see a lot more we could do around expectations and oversight. We actually have a lot of regulatory framework, but if you don't provide that oversight and have hold operators accountable, you're going to allow unintended consequences and things to happen. And how have we aligned the funding incentives, et cetera, et cetera. So that's all a roundabout way of saying that I think that for very practical reasons, we are going to continue to see governments use existing private care homes to deliver publicly funded services. There's just a lot of them that are doing it now. You can't change that over. So I think you're going to see that continue. Where new care beds are, I think that we'll have to see how that evolves. For the ones where they are existing care homes, I think that we are going to see more oversight. The people have been awakened, and the people have said, because most people never see the inside of a care home. Most people are never in a care home. Now they know what it looks like. And they're saying, no, we really have to do something here. And so I think that we will see that increased accountability and oversight in the months and years ahead.
Isobel, I think this is the end of our webinar with you. I want to thank you very much for sharing your strength and knowledge and experience with us and with our communities here on the North Shore of Vancouver. One last thing, can you tell us when the survey results will be made public from your most recent survey that just, I think, closed last night?
Yes, our target date last week of October. So I think probably we're aiming to do it on the 27th or the 28th of October. We've got a lot of work to do to take these, all this data and sort it through and put it out in a coherent way. But I am very committed that we will get it out before the end of October.
Great, thank you very much. We've had a lot of very good questions from our seniors out there in the community. I thank you all for being here with us. Maybe we'll try to get Bonnie Henry onto a webinar as well. So speak to Anwin or West Vancouver Senior Center or myself at Parkgate, and we'll see what we can do. This has been very educational, I'm sure, for the seniors, certainly for me, and the amount of work that you're doing for seniors. We're very lucky to have you in British Columbia, and this has been a very good thing for us since 2013 when you came onto the scene. So thank you very much, Isobel. Thank you to everybody else who is out there, and I hope to see you all soon.
Okay, and I hope to be back on the North Shore. I do.
Good.
Okay, all right. Thank you.
Thanks, Isobel.
All right.